series looking at inequalities in transport in low-income communities, in low-income countries. We have a great set of people presenting today. And without further ado, I'm going to pass over to our moderator, Dario Hidalgo, who will basically give us a brief introduction to each of the speakers. We'll take questions and answers on the chat at the end, where he will be also participating in our moderated debate. So over to you, Dario.
Well, thank you so much, Karen, and I'm very, very happy to join the series today as moderator. We have Thiago Guimarães. He works with the World Resources Institute, but he comes on his research capacity today to join us and share experiences from access to health, evidence from low-income communities in São Paulo, Brazil. We also have Professor Marianne Vanderschuren from the University of Cape Town in South Africa. And she's also looking at the experience of Cape Town on how do informal settlements compare. It's a very, very interesting look from the global south. And then the last presentation by Haneen Khreis. Well, actually, we don't have here. We have Marianne on behalf of the Texas A&M University, and it's also looking at perspective from the global south in terms of air pollution and human health. So thank you so much for joining us today, and we are very, very happy to continue this series. Each presentation will be around 15 minutes, and we are ready to take your questions and pass it to the presenters. Thank you so much. My name is Dario Hidalgo. I work independently now in the city of Bogota, Colombia. I have been affiliated with the World Resources Institute over several years, and I'm doing research from Bogota, Colombia. So Thiago, it's your turn. So you just share the screen and come up.
Yes, first, good morning, everybody, or good afternoon. Thanks, Rafael, Danielle, Karen, for inviting me for joining the seminar series. I've been joining previous sessions with, it's been a great pleasure to see what people have been sharing here in this space. Let's start the presentation today on transport and access to healthcare in Brazil, in the Brazilian city of São Paulo. This is just I'm just going to share some findings of my PhD research done undertaken at the University of Leeds and concluded some months ago. What I'm going to basically talk about today is focused on the empirical parts of my work, while there are some also important conceptual issues that I developed better in the PhD thesis that should be available right now in this link. Just for some initial comments on what's happening here in Brazil. We are in the forefront of the news regarding COVID development, and there's a huge increase of numbers of cases also in the city of São Paulo, which is the focus of my case study. And that's very impressive how a situation of overcrowding in public transport has remained over the past weeks, despite reduction in public transport announced by the public authorities. And then the authorities also announced an increase in the public transport. The situation of overcrowding in public transport remained the same. And right now the situation is not so different from before. That's quite impressive to see how things are developing here. And also the pattern of the dissemination of this disease follows, it's more and more clear how the pattern of dissemination affects more some areas, some areas in the outskirts of the city, some urban fringes. And that's quite well related or associated with the spatial pattern of poverty and social deprivation as well. As in other Latin American cities, we do have the center-periphery pattern of distribution, whereby the rich districts are more concentrated in the center of the city, where the poor districts are located in the more distant areas. And this is apparently and also statistically very closely related to the rates of healthcare utilization and also the health outcome. So if you see here, the share of women that do the minimum number of prenatal care appointments, or the average age at death, you see almost the same pattern here. The research background is to try to investigate to what extent accessibility or the spatial access is an important component of access to healthcare within this utilization and the links to utilization of healthcare services, and therefore the links to healthcare outcomes. Accessibility is generally understood as the easy or the individual ability to get to activity sites, and is typically operationalized in terms of travel time or cost. And according to, well, for the Brazilian setting, we do know that the poorest population groups, they feel more that the distance and difficulties with transport are indeed related to, are given as main reasons for people not to seek healthcare. What is an evidence that, well, spatial access matter for healthcare utilization and health outcomes. In an early moment of my research, I also analyzed like this the role of distance and time for people to access healthcare facilities. That are these yellow dots here in this map, and you see that like the people that are living in the urban fringe do not necessarily have low level of physical accessibility or spatial accessibility to healthcare facilities. Here, sorry, I don't have the legend here for this map, but the darker the areas, the better the level of spatial access. You see here some several areas in that are poor, according to the spatial pattern of income distribution, that have relatively good access to healthcare facilities in the city of São Paulo. So the point here is, what I'm trying to investigate the relationship between accessibility and healthcare uptake and healthcare utilization and outcomes. And we do know that there are some mixed results about the association between distance to healthcare and health outcomes. And this relationship, although this relationship has been quite clear in rural or in sparsely settled regions, in the intra-city, intra-urban or metropolitan settings, this relationship is less clear. And we don't know so exactly also, there's missing explanations about the causal mechanisms linking the easy to travel to healthcare sites and utilization. And that's what my research is trying to address. Also important to say here is that there are some evidence saying that the quality of healthcare may be important for the definition of healthcare landscapes. For instance, in this North American setting here, whereby an African-American individual here has in his accessibility threshold 5 healthcare sites to choose, but in fact, actually, he does travel to another clinic outside this threshold here. So what I'm going to talk about is, or to try to address in this research, is which are the key barriers faced by residents of low-income areas in São Paulo when accessing healthcare services, and how do poor people overcome these barriers in order to satisfy their health needs. Just 2 words about the healthcare system in Brazil. We do have like actually a hybrid system. We have the public healthcare system it's quite relatively similar to the one that you find, for instance, in the United Kingdom, with a public, universal, cost-free, unconditional system, or a system that provides unconditional access to healthcare, funded basically by the government. But there are also some evidence that this system underperforms, is underfunded, and provides service care of low quality. And you have in parallel also a private healthcare system whereby people pay up to, let's say, around $2,000 per month to have private healthcare. This research took a qualitative approach. I conducted 15 focus groups with 114 participants over 7 districts and 12 neighborhoods in São Paulo in order to understand accessibility based and grounded on the context of citizens' experiences and perspectives. And here's my case study area. You can see here that one of my main motivations to develop this research was also to assess a huge transport investment. Here is that you have like a monorail link, and that was the defining guidance for defining this case study area. There's a huge amount of money to be invested in this link, and my background question was, does it make sense to invest that amount of money to improve accessibility to healthcare for those people? And you see here that in these pink dots, the residence places of the people that I've talked to. And indeed, with this design, I was able to talk to people who live in very poor conditions, that they live in poor areas. Half was living in less than 1 kilometer of stations of this future monorail line, while the other half was living over 1 kilometer from this outside this buffer. And there's an intended bias towards female participants, because they are more in charge of taking care of himself and other household members. They were more able to talk about healthcare in Brazil. So, and what I identified from them was that accessibility to healthcare actually can be framed in terms of 5 key barriers that I'm talking now. So the barriers are, one of course is like the remoteness in the sense of spatial distance to healthcare sites. People do appreciate living close to equipment, to healthcare facilities, and distance time is like a kind of obvious dimension of accessibility. And but the absolute lack of local opportunities was a restricted problem, as we could imagine in this urban setting, very dense setting. In general, it's easier to get to basic healthcare facilities than to more specialized services in the hospitals. The second one was walking safety. So people feel difficult to reach walking and some healthcare facilities because of problems of the walking environment in relation to the driver's behavior as well. It was like the relatedness between these two issues that make it difficult for people to walk safely to healthcare sites. Then the third barrier was was related to public transport. Over 50% of people go in São Paulo, travel to healthcare sites using public transport modes. And there are, this barrier could be better defined in 4 sub-themes. One was the availability. There are few lines serving destinations of interest, like hospitals and healthcare sites, low service of the services at off-peak times, and physical inaccessible services for people with disabilities, for instance. The problem of affordability was not framed in absolute terms, but rather in a sense of the value of money for using the services, because you have to pay a relatively high fee to use uncomfortable public transport modes. The comfort itself was a very huge issue. And in particular, the overcrowding in all stages of the trip was expressed by participants, and the problem of reliability. People cannot trust when public transport can be used. Then the fourth barrier was personal security, not only assaults and the risk of fearing of being vulnerable to this kind of crime, but also female harassment. Remembering then that 2/3 of the trips to healthcare in São Paulo are made by women. There are no other trip purpose that's so biased towards gender biased as healthcare trips. And this has been overseen by the transport planning community. And the fifth barrier is the quality of healthcare services, indeed. So you have waiting time for the consultation. So between you try to have appointment and have this appointment. In fact, you have to wait sometimes months for getting this appointment. You have the waiting time on the day of your consultation, and people queuing hours for having like a hospital an appointment with the doctor. And the quality of consultation has been regarded for several participants as poor as well. Rushed consultations, inattentive, and so on. So therefore these 5 barriers and the relatedness between them. And most important, for instance, you have like this trade-off between distance and quality, that people regard proximity as something good, but only in relation to opportunities that are able to deliver service with satisfactory quality. And perhaps more important in this research, that we could also link these barriers with some outcomes of the barriers. I found some causal links between problems pertaining to the transport domain as well as to the healthcare domain, and how they, which are the implications of these barriers to people actually, that they then develop short-term and long-term strategies in order to overcome these barriers. For instance, people may be traveling to other services on the day of their consultations when they face the lack of medical staff in a particular equipment, or materials lacking, or some equipment is lacking. I just have some new evidence now during this COVID time, the research published last week, that 85% of the health professionals in Brazil reported lack of thermometers in basic healthcare units, for instance, you know, or lack of drugs, basic drugs for fighting some viruses. And that's the problem faced by poor people in the case of São Paulo as well, that then maybe traveling to other more distant services, or also engaging in a quite complex trip chaining in order to overcome this complexity and these difficulties. And in the long term, they may be traveling farther as well. Also, well, because of this healthcare problems, but also because of the transport issue. So the key find is first that the accessibility should be framed as a plural, involves a plural barriers actually. Travel time and distance are not the sole, or not, or even not the most important healthcare accessibility barrier. These barriers are usually interconnected. So people access jointly transport and healthcare service attributes when accessing the easy to get to healthcare sites. There's also some kind of evidence on some hierarchy, that because people often accept to travel in inferior conditions, or to more distant, you know, in uncomfortable situations, when they expect, even if they don't know exactly, they don't have a proof of, but they expect to use healthcare services of superior quality. And accessibility barriers and their interactions lead to negative outcomes in terms of satisfaction of health needs. This leads us to our last slide. Policy recommendations would be to improve this institutional cross-sectoral coordination for thinking transport, urban, and service planning together. Quality improvement of local healthcare, of course, could be something to be pursued in order to eliminate regional disparities in the quality of healthcare within the city. Perhaps as in a first moment, you could also flexibilize the primary, this territorial approach for primary healthcare provision. Public transport is a huge area for improvement, but not in terms of making it more rapid to get to the places faster, but it's rather about accessibility in terms of comfort, reliability, and safety. And enhancing walking conditions would be a good thing to do in a setting where over 90% of the sidewalks are considered inappropriate. That's all. Thank you very much.
Thanks, Thiago. Just in time. There's a quick question just to give some additional background. At the beginning of your presentation, you showed the prevalence of COVID and in the city of São Paulo, and the question would be, is more prevalent in these low-income areas? To just clarify to the audience if that's the case, and so this access to healthcare facility is so important for low-income population.
Yeah, that's the interesting thing. São Paulo was the first city where COVID arrived actually from Europe in Brazil. And so it was like the entrance point of COVID in Brazil. And it started in a high income area within the city. But then it moved, I had, because of time, I had to skip it. I couldn't develop it so in depth. But the point was, although initially you had all the chances to have like these epidemics developing very quickly in high income areas, the opposite happened, in fact. So the poorer area of the city had the highest number of cases within a small number of weeks. It was the opposite of what happened. It was a change of pattern very quickly.
There's another question, just to take it fast, and then we continue with the presentations and come back to the discussion later on. But the question comes from Tania de Freitas de Oliveira, also from Brazil. And she wants to know that if there's a causal relationship between the lack of access to healthcare and the health uptake. Do you believe there's enough data research to indicate where more infrastructure is needed in these areas? It should be provided by government or better access?
I didn't understand the question. Investment in which area?
Do you think that there's enough research information to provide the government with the idea of providing more facilities in these areas, or providing better access through public transportation, for instance?
Well, according to my research, the people prefer well, we should be careful in giving too much weight for transport measures in the transport sector. What people need is more healthcare of good quality, actually.
Okay.
But if you see the distribution in São Paulo, for instance, there are many facilities in the low income areas. There are perhaps enough healthcare facilities in the low income areas, but the quality of them is the key question.
Okay.
Yeah.
Thank you very much, Thiago. With that, we move to the next presentation from Marianne, and we really appreciate. If there are more questions for Thiago, we will be able to take it at the end of the session. So Marianne, if you are able to bring your screen up and share your presentation, please.
Sorry, something is happening here with my... Okay, can everybody see this?
Yes.
Thank you. I have now a flicker in the video that I see, but I'm happy that everybody can see my screen properly. So I'm going to ignore that. So thank you very much. Thank you for the invitation. And I would like to talk to you about transport in Cape Town, how informal settlements compare, and given COVID and the rest of the country, and maybe not everybody understanding what is happening in the global south, I will also talk a little bit further about other aspects. So I will start with a background that actually sets where how I look at healthcare facilities and access to healthcare. Then I'll give you some data on healthcare facilities in South Africa and healthcare facilities in the Western Cape and Cape Town. And then I decided to actually look at vulnerable groups, because it's not only vulnerable areas, it's also vulnerable groups of people in Cape Town, and seeing how they access healthcare and how they differ from other parts of the population. And then I finished with some security risks in the transport system, and that is, like Thiago did, related to COVID. So I think if we're thinking about healthcare, we need to keep the Sustainable Development Goals in mind. And it speaks directly to Sustainable Development Goal 3, ensuring healthy living for and promote well-being for all of all ages. So what does it mean? Health is a fundamental human right and a key indicator of sustainable development. Poor health threatens the risk of children not being able to access education, men and women not being able to access economic opportunities, and it increases poverty. And that's obviously one of the big issues in South Africa and the rest of Africa. In addition, it causes poverty. Health is impacted by poverty and strongly connected to aspects, other sustainable development aspects, such as water sanitation. There is a gender equity issue around this, and it has relations to climate change, peace, and stability in a region. We also need to keep in mind that there is a specific goal that is transport related, and that is target 3.6 under the Sustainable Development Goal of Health. And in that target, the aim was, and I'm now speaking in the past, to halve the number of global deaths due to injuries in road traffic. We haven't been able to do that, and I will just touch a little bit on road fatalities as well. So if we're looking at South Africa and compared to globally, we are a middle income country. And in the graph on your left-hand side, you will see the access to medical doctors per 1,000 population. The blue line is for high income countries. The orange line is for low income countries. So you can see already a huge difference of currently more or less, or in 2000 more or less, 2.5, maybe in some countries even 3 medical doctors per 1,000 inhabitants, and maybe half a doctor per 1,000 in low income countries. Middle income countries is the yellow line, and you can see here that that line has been declining over the past years. And you can also see with the green line that although we are a middle income country, overall in the nation, the access to healthcare and medical doctors is not very good in the South African context. The graph on the side shows you the average, and this is more recent data, it carries on a little bit further. You can see the average number of doctors in the Republic of South Africa, which is just over a half, 0.7 it was, if I remember correctly. And only the Western Cape gets to more or less the average of middle income countries. And Cape Town is in the Western Cape. Gauteng, the major economic hub, doesn't have as many, but it has more than 1.3 more or less. So that gives you a first indication of how access to healthcare is in the South African context. To the figure on the right, carrying on with that data, if you look in the National Household Travel at the average travel time per province to healthcare facilities, there are some provinces where there are households that have a travel time to healthcare facilities of more than 5 hours. Now try to imagine yourself living in those type of areas. And I have even, what you will see is that the Western Cape is not in this figure. So theoretically, everybody in the Western Cape should be able to get to healthcare at least within that 5-hour period. But I have heard situations where people traveled to Khreis Hospital, which is one of the big hospitals in Cape Town that is a provincial hospital, and where people arrive with their sick children that have died on the trip to the hospital, and that's just the stories that you hear often. On the left-hand side, you see an analysis with relation to road safety. So the red dots are all the road fatalities over a 4 or 5 year period in the Western Cape. You see that Cape Town is blocked out. So that orangey area is the Cape Town area. And when we were doing the study, to also be able to visualize what we are doing, is we assumed that if you are in Cape Town, there are a lot of clinics and hospitals, and you would be able to get to emergency services. An ambulance would pick you up and you would get there. Now the question is, in rural areas, if you are traveling and you need emergency care, can you get there? So you see green areas in this picture in the rural parts of the Western Cape. And those are the areas that indicate the areas where there are emergency services, and the green area around it, the area, yeah, the catchment around it indicates the 1 hour travel time that you would have from the ambulance to be dispatched to being able to pick up a person that is injured and bringing him or her back to the hospital. You see a huge amount of red dots that don't fall within this. And when we were doing the analysis, 56% of the provincial roads, you have no chance to be able to be admitted to a hospital within that. In health sciences, they call it the golden hour, within 1 hour that you need to get to emergency services to increase your the possibility or your survival rate. So that gives already an indication that even in a province where there theoretically is quite good service, there is the accessibility of healthcare if you're on the road is not very good. Just to give you an indication, 1 in 5 accidents happen in Cape Town itself, but 1 in 2 fatalities happen in the rural areas. It gives you an indication of the difference between accessibility to healthcare. If we then focus on Cape Town, and unfortunately I didn't have the time, forgive me, to put this in a geographical system. So you see the different traffic analysis zones in Cape Town and what mode of transport different people use to get to medical facilities. If we look at Khreis, which is the largest and fastest growing township in South Africa, not even Cape Town, in South Africa, you see that the majority of people will walk to get help or use a minibus taxi to help. Bus and train were so small that I actually combined them. If you look at Mitchell's Plain and Gugulethu, the situation is very similar. And together, Gugulethu and Mitchell's Plain have a similar amount of inhabitants as in Khreis on its own. A few other townships are Lange and Bishopslaver, Belgravia, and Blue Downs. And you see that the number of walking trips and minibus taxi trips are big for all of those areas. Car trips are very limited. So the burden on traveling to facilities is clearly higher for people in these areas. Just to give you a better idea, and now I'm not sure if I can move this away. Let me just try this quickly. No, it's I can't. Oh, no, something. My apologies. I was trying to get the flickering videos out of my screen, but I hope that everybody else can see it. So you can see for all trips to medical facilities for the whole of Cape Town, you see that car is quite important, where it becomes very, very small in 12% in an area such as Khreis, and that is very similar in the other poorer areas. If we, then I thought, is the area really the, what we need to look at? And we know that there are some wealthier households, for example, in Khreis and Gugulethu as well. So then I used the same data, but instead of looking per area, I decided to use grant holders as the indicator to identify vulnerable users. And what you can see is that of grant holders, that a big part of them actually use train, even if train is quite small. And they clearly have less, very clearly less car trips. So 88% of trips are by non-grant holders, if I can call it that, people that have other income sources, and people that have grants just don't have access to private cars. If we look at, and one of the things bringing COVID into this, I thought there was in the media as well, the first day that grants could be collected in South Africa after the lockdown. We locked down at the end of March. So then people started going, they had to go and collect their grants. And you see this huge queue of vulnerable people. In those days, it was still quite hot, etc. And that day, actually 3 people queuing for their money passed away in the queues. It was just horrendous to see the news at that time. That just gives you an idea of how difficult the situation is. Travel time as well, you can see that the travel time is significantly longer for grant holders to be able to get to medical facilities as for people that have other income sources. The group that has 16 to 30 minutes or even more, it's much higher, and it's almost 50% of grant holders travel that long. And this is in Cape Town, where we assumed that facilities are quite dense. Another group that I pointed out, and they're suffering in some cases even more, is the people with no income. They look very similar to grant holders, but we have people that have no steady income trying to access medical facilities. I'm just going to check the time. Another aspect is the vulnerability.
You've got 2 minutes, Marianne.
Thank you. The vulnerability of road users when they are traveling. So people that are traveling in public transport are exposed to crime and violence. And in some cases, for example, for Metro Rail in Cape Town, over 60% indicate that they find the trip to the station very unsafe or unsafe. So safety and the perception of safety is a clear issue. This is even worse for females. They feel even more vulnerable. And when we did some interviews on the rail, you can see that where the types of harassment that males are exposed to is pickpocketing and muggings. They're not really confronted. Where females also have issues with verbal harassment and even sexual harassments. There are stories of people getting raped while they're using the train. And this was data collected on the safest train route in Cape Town. With regards to COVID, this just exacerbates the risk factors. We do have initiatives to make sure that we treat the vehicles when they get to the ranks. We do have a reduction in the number of people that can use public transport, but that also has caused an increase in the price, because if a minibus taxi can travel with less passengers, then obviously they will need to increase their prices. And then there is a risk with regards to suffering because not being able to access, for example, vaccines. Immunization for children is, for example, a problem because the trade to South Africa and other parts of Africa has not increased. And I know the World Health Organization has indicated that the number of fatalities in Africa due to this problem could be as big, if not bigger, than the COVID deaths that we will have on the African continent. And then the taxis, there were negotiations by the minister and Santaco, the main union for minibus taxis. And, you know, if you want us to travel with less people and not increase the prices, that's not going to happen. So we'll have some hand signs to indicate that we are not accepting this. Huge issues nowadays around these type of negotiations. And with that said, I would like to thank everybody that has been involved over time with this research and ongoing research, and also thank you for the opportunity to talk. That's it
Marianne,
from me.
thank you so much. And we see linkages to the Brazilian situation in terms of access, especially for low income, and also the gender perspective, which is very, very, very important. We have a couple of discussions on the chat while you were speaking. One on including air quality in the health outcomes, but it is in a different SDG. It is not under health, but it is an important aspect of transport. And the other was on the travel time, especially walking to these facilities, which is much more expanded. What would you just respond on the walking time to these facilities, and what is the influence on lack of access when you need to do it by walking and the facilities are not there or the distance is too large?
Yeah, I'm going to quickly pull the slide up on my screen while the right side, because it was not very visible when I was talking to you because of the pictures being in the area. So if you look at the average walking time, and this is average, as I said, there is a big span, then on average people walk just under 20 minutes to be able to get to a medical facility. I hope that that answers that question. That's more or less the same for people. So for people with a grant, without a grant, or no income at all. Does that answer the person's question?
I think it does. The other, and Heather Allen also comes with an important point. We were shocked by the fact that many other deaths are happening because of the difficulties that the system is having right now. What about maternal health and new births? Do you have any data on that?
Yeah, at the moment people are just very afraid to go to the hospital. So a lot has been delayed, and obviously, you know, when you're pregnant, there is no delaying of delivering your baby. So what we haven't seen in South Africa as much yet, in a few pockets, yes, but when the information from Europe was coming out, there were big issues as with regards to healthcare facilities and doctors and nurses getting sick. So therefore, there was a lot of pressure on providing also general care. We haven't seen that yet in the South African context, except maybe one or two hospitals. And we have, because we went to a complete lockdown, we weren't allowed to travel at all for 6 weeks. We have been able to have COVID-related emergency facilities in conference centers, etc., and therefore, as far as I'm aware, for example, pregnancy care, etc., is still happening if they can get all the materials, medicine, etc. in. PPA for COVID is also an issue. So the trade issue in the background is still an issue, and the immunization of babies is, for example, an issue.
Thank you, Marianne. We move on. There are other questions that we will try to capture at the end. Now we move to Haneen. Thanks a lot for preparing your presentation and coming. And please take up the stage.
Thanks, Dario. So let me start by sharing my screen. Okay, yeah, thanks, Dario, and thank you, Karen and Daniel, also for the invitation. I'm going to be talking about traffic-related air pollution and human health. Most of my research, well, actually, all of my research has been in the global north. So it took me some research to put this presentation together, and you know, some of the results or what I've seen in the literature is definitely worth commenting on. So currently, my name is Khreis. I'm an associate research scientist at the Texas A&M Transportation Institute. I'm also an associated researcher at the Barcelona's Institute for Global Health. I work on transportation and health in general, although I started working on air quality. And before I get on with the presentation and focus on air quality or on traffic-related air pollution in particular, I wanted just to kind of put this into the wider context that transportation is linked to health through so many pathways beyond air quality. So this is a framework that we recently came up with, looking at different transportation factors or transportation decisions, which is the top part of this graphic, and what kind of exposures, environmental exposures or lifestyles these decisions affect, and what that means for morbidity and premature mortality. And I'm going to show you just a little bit more on this. So if we move on and look at these pathways, what we call pathways to health, where there is evidence that these exposures are linked to transportation, we see 14 pathways. One of them is air pollution, and it's a very important one. But depending on where you are, on contextual factors, on your baseline health conditions, on the city planning and the transportation planning in cities, some of these pathways can actually be more important than air pollution. So while it's very important to think about air quality and improve it by reducing traffic emissions, these other pathways, like you can see, physical activity, green spaces, access, we've already talked about access a lot in today's session, mobility independence are also important. And on the other side of the graphic are 10 pathways that are detrimental to health, including noise, urban heat, motor vehicle crashes. So just to kind of put things into perspective, air quality is important, and I'll be focusing on it for the rest of the presentation. But a lot of these other factors, they have a similar or even a higher burden of disease in cities specifically. So moving on, just thinking about traffic-related air pollution in particular. The way we've been framing it and thinking about it is using this kind of full chain framework that links traffic activity to its ultimate health impacts. So between traffic activity and the ultimate health impacts, there are many events or many elements of this full chain. So, traffic emits both tailpipe and non-tailpipe pollutants, which is the non-tailpipe is quite important now since we've been reducing tailpipe emissions, and since we're talking about electric vehicles, which would eliminate tailpipe emissions, at least in cities. These emissions disperse in the ambient air depending on things like meteorological factors, the layout of cities, the trees covers, and many other factors. It's a very dynamic process. And that dispersion results in poor air quality or air pollution levels that people then are exposed to. And these exposures ultimately result in a very wide range of health impacts that we're just beginning to fully understand. And that range keeps increasing as we do more research. On the upstream of this chain, I have this kind of technologies and disruptors icon, which refers to all these emerging transportation technologies like connected and automated vehicles and electric vehicles that have a big impact and actually many unintended consequences on emissions and human exposures. So that's kind of the framework that I personally use in my research. And it's a useful one because what it means is that you can attribute certain health impacts specifically back to the source of air pollution that's responsible for them. In this case, we're interested in transportation or in road traffic. Now, in terms of the health effects or the health impacts of traffic-related air pollution, a lot of these health effects are similar to the health effects of air pollution in general. Some of them are a bit more specific to traffic, and this is a range of health effects that have been kind of well established in the literature, mainly by systematic reviews and meta-analysis. So you can see how wide that range is. And also we've been seeing a lot of new or emerging outcomes like obesity, like bone mineral density loss. So these are new things that we're learning about with more research. And I'll talk more about this in the burden of disease assessment exercise. We kind of tend to generally underestimate the burden of air pollution because we don't take all these health effects into account once we do these health impact assessments or these burden of disease assessments. Now, moving on, I really want to focus now on the geographical distribution of both research and air quality around the world. So this is a graphic that comes from an important WHO report a few years back that shows where the location of monitoring stations for PM 2.5, so that's fine particulate matter that has been linked to that have been linked to a wide range of disease and also premature mortality in a lot of studies. So this is just looking at where this pollutant is monitored around the world, and where those levels are high and where they're low, this kind of 10 microgram per meter cubic, that's the World Health Organization guideline. It's a health-based guideline or recommendation. So, I mean, what we see here, which is quite clear, is that these stations or these monitoring networks are much more dense in the global north, especially in the United States and in big parts of Europe. And they're much fewer in the global south, especially in places like Africa and Latin America. But also, if we look at the levels of air pollution, we also see that the levels are usually higher and they're exceeding the WHO standard in the global south. So, you know, while these monitors give us a good indication, obviously to different extents in the global south and global north, when we do health impact assessments or burden of disease assessments, we do need estimates of exposures for all areas, including those that may not be covered by ground monitoring networks. So what I'm showing here is also another graphic from the same report where the WHO did a modeling exercise to come up with exposure estimates for PM 2.5 in those areas where no monitoring is available. And again, looking at the levels, you know, that kind of stark difference or that stark, I guess, unequal distribution of air pollution is quite clear when you look at the global south and the global north. You know, parts of Africa, even Eastern Europe, India, China, and the Middle East are the biggest regional dangerous spots for PM 2.5. The WHO actually says in this report that almost all air pollution related deaths, around 94% of them, they occur in low and middle income countries. So moving forward and looking at the health impact of these air pollution levels, I mean, I just showed the monitoring network and I just showed the model concentrations of air quality. But if we look at the health impacts, which is why, for example, I'm personally interested in air pollution, it does have a lot of other impacts, but health is, I would argue, the most important. So this is a graphic that's coming from a report by the Health Effects Institute last year in their State of Global Air. And this is looking at the number or the rate of air pollution attributable deaths in a given year. So these are premature mortalities. So these are deaths that would have likely occurred earlier than we would expect they would if those same people were not exposed to the levels of PM 2.5. And again, you know, same pattern as we see with the monitoring network, the levels of air pollution as measured in the monitoring network and also in the modeled concentrations or the maps. Most of the health burden is happening in the global south, but also more in Eastern Europe as well. But this is how the standardized death rates look like in 2017. Now, it's important when we think about air quality, not just to think about premature mortality. It's a very important outcome that also has a lot of weight when we think about, for example, transportation investment appraisals, because the value of statistical life carries a lot of weight. But we also think about disease, and a lot of diseases in that graphic that I just showed on the health effects of air pollution are chronic diseases. So there are things that people carry across their lifetime. So they can also be very costly and obviously have a big impact on the quality of life for individuals and their caregivers. So what I'm showing here is a metric called DALYs, which is Disability Adjusted Life Years. It's a metric or a measure that includes both the number of healthy years of life that we lose from air pollution because of premature mortality, but it also includes disability and the years of life lived with disability, for example, a paralysis from a stroke related to air pollution, combined in one measure. And again, you know, very, very similar trends to what we see in all the other graphics. So, you know, there's a very clear unequal distribution of air pollution and its health impacts around the world. So I've been showing results for PM2.5 because it's a pollutant that has a lot of health evidence to show that it elicits a lot of adverse health effects. That kind of evidence base is well established. But when we think about PM2.5 and the coarser particles, PM10, they have a lot of sources. It's not just traffic, so they can come from many other sources, including, you know, industry, domestic fuel burning, and also natural sources. And for us to be able to disentangle the sources, we need to have source apportionment source apportionment studies or full chain analysis. And if we look at studies or at the literature that has been, you know, across the world, we also see that those studies are much less in the global south. So while we have a lot of information on where air pollution comes from in the global north, we don't have as many studies or as much research conducted in the global south. So we're not always able to say where those air pollution levels come from, which is obviously very important for targeted policies and for policy making. So I found this kind of interesting systematic review where the authors looked at studies of source apportionment from around the world, and they did give some indication on the average contribution of different sources to PM2.5 and PM10 across the world. And this is really to show what the role of traffic in these air pollution levels is, and also the health burden associated with these air pollution levels. So as we can see, if we look at places like, for example, Brazil, traffic is a contributor to 34% of PM2.5. The rest of the Americas, 30%. If we look at Africa, that percentage is 17. The Middle East, 12. Southern Asia, 34%. And then other places like Southeastern Asia is 36%. So there's obviously a wide range of these percentages, but in many places, these are important. So if we look at Latin America, actually traffic is the main contributor to PM2.5. If we move on and look at PM10, and PM10 is a pollutant that is more associated with heavy duty vehicles specifically, and older vehicles as well. We see that these percentages increase in most places. So for example, in Latin America, we're looking at 38%. It's again the biggest contributor to PM10 concentrations in ambient air. If we look at Africa, that percent compared to PM2.5 also increases significantly. Similar in the Middle East, in India, it's quite high, southern China. So again, wide range, but it just really highlights the importance of traffic as a major contributor to these air pollution levels, and as an important source to target if we are going to reduce the health burden associated with poor air quality. So this is a really more general, higher level overview of the distribution of air pollution and the health impacts associated with it across the world. But I do want to make some final notes for us to keep in mind. So as I said earlier, many of the health effects associated with air pollution are still not accounted for in global burden of disease estimates. So even those graphics where I showed premature mortality and DALYs, there are many new health effects that we're discovering recently that are not accounted for, and some of them that are even more well established but are still not accounted for. So the true burden of air pollution across the whole world, but specifically in the global south, is likely to be very underestimated. Also importantly, there's a lot of research right now to show that the health effects of air pollution actually occur below the WHO guidelines and even national air quality standards in most places in the world. So we're seeing health effects or adverse health effects at relatively low levels of low levels of air pollution. And while I talked about PM2.5 and PM10, these pollutants are not exactly traffic specific. As we saw, you know, the percentages can vary between 12, 15% to 34%. There are other pollutants like nitrogen dioxide, black carbon, and ultrafine particles, which track traffic activity much better. But the studies on them and their health burden, specifically in the global south, are very few. So we don't really have a great understanding of the contribution of traffic to ill health in the global south. And finally, I think, you know, just looking at this data, I think there's plenty to say that there is an issue and an issue of inequality, but we do need further data collection on the sources specifically contributing to air pollution, specifically in the global south. Few data, including Africa, even Eastern Europe and Northern Africa. So with that, I'll end and actually do a little plug-in for our new books on transportation and health in general, looking at the other 13 pathways, and a book that's coming up next month on traffic-related air pollution that looks at the full chain that I just talked about between traffic activity and health. And I will end here.
Thank you, Haneen. It has been really, really interesting to go the whole way, and we had in the chat a very interesting discussion on these general metrics of air quality, the lack of measurement, especially in African countries, but this talks about the averages, and we have roadside exposure and we have in-vehicle exposure that are also important in some places. But your call for having more monitoring and especially apportionment of the sources is very, very important, because that's what is needed for policy. Would you think that the modeling practice and the activity that is going there in terms of modeling is helpful, or you still need a lot of local data?
I mean, the modeling is usually, in my kind of opinion, it's usually a compromise for when your data is missing. So monitoring is better because it's actual measured levels, assuming that your monitoring devices are well calibrated. But having said that, they are expensive and they're very few. And if you want to use, you know, regulatory monitoring devices, they're extremely expensive and hard to maintain. So modeling is a good, you know, it's a good compromise. It's a good exercise as long as you validate. And I think it's useful, yes.
Thank you. Yeah, we have some minutes for discussion. So I invite to continue providing questions in the Q&A rather than the chat. It's easier to manage in the Q&A. And we have questions that go for Thiago, also for Marianne, and then for Haneen. For Thiago, there's this question again from Ignacio Tiznado. He brought up two questions. Is there a consideration between land use and transport planning in Brazil? In your opinion, is it possible to tackle these accessibility healthcare barriers in a more comprehensive way, understanding the interconnected role of local fatalities, transport services, and walking environment? And the second, when I gave the two questions from Ignacio, had suggest interventions to improve access to health with low budget. Would you prioritize transport-related barriers? You kind of answered that in the previous session, but can you expand on that, on the compromise of locating facilities and or providing better access? Thank you.
Yes, I think that in terms of accessibility, which I should remark, that's like a small share of research has been dedicated to, right? Like Haneen provided this whole framework of transport and health links, and accessibility is like just a small share of this whole body of research. But even within the accessibility research, I think research has been overlooked the qualities of the facilities. So we have been thinking very more precisely on let's say, on modeling in very high spatial resolution levels, getting more complex data, more detailed data on transport networks and so on. And to a certain extent also to look at the characteristics of the social demographic characteristics of people who need to get to these facilities. But we have been overlooking the quality part. So, like, which kind of facilities we need to access? Are they public, private? Do they provide good or bad services and so on? And I think that when Ignacio asked about the possible links between land use and transport, I agree with him. I think that I respond to him. I don't know if everybody has access to the Q&A section here, but I do think that Brazil has, and other global south countries, at least in Latin America, has also improved with regards to establishing legal frameworks that promote this interconnectedness between land use and transport planning. But what's missing, in my view, is also that to take into account, to involve also the service providers as well, the service planners, the health community, in order to provide good solutions to the accessibility problem. And with regard to the cost of interventions, I didn't calculate the financial burden of each intervention that we may suggest, but I do know that, for instance, many global south cities are now trying to implement a more strict trunk feed system of public transport, where you have like the local buses serving like the lines that connect the regional centralities to the CBDs or to the city centers. And this kind of model or this kind of pattern, it imposes a cost also for people. Perhaps we should think in redesigning bus lines, in also take into account the location of facilities that provide good care and necessary care for wide populations in order to improve their accessibility. I think that would be the most one of the best cost-effective solutions for this issue.
Thank you, Thiago. Very good point, and you're raising a strong point on not just the location but the quality of the facilities. I think it's one very important point that came out of your research and recommendations. For Marianne, there was a discussion on the chat on mobile healthcare facilities. She responded in the chat, but probably better to answer Jackie Klopp openly for everybody.
Yeah, Jackie
Marianne.
asked if there, thank you, Darius. Jackie asked if there was a mobile facilities, and other than nurses that go to people's homes, there are no facilities. I did do some analysis in that report on road safety, and we looked at if we distribute ambulances or motorbike ambulances into the rural areas, what are the effects? And we found that the benefits go up to over $300 of benefits for every dollar that you invest. That's especially kind of when you look extreme. At motorbike, yeah, very extreme. Especially if you look at motorbikes. So we looked all the way from helicopters to normal traditional ambulances and motorcycles. And for a motorcycle to be in the field, being able to stabilize a patient, and in our calculations then in the meantime the ambulance coming to pick up that patient would benefit about $300 for every dollar you invest into motorbikes. Recently I saw even motorbikes with a little side cart, and that's not something new. We had that in the olden days as well. So even that is now introduced in the Eastern Cape in these COVID situations where motorbikes can get better into the rural areas and go and pick up COVID-related people. So other than that, there is nothing. Do you want me to address the second question to me as well? Yes,
it's a question on the minibuses, please.
Yeah, so it's about electrification of minibuses, or maybe we should do something else. I think firstly we need to understand that if we do electrification, even if it's of minibuses and not private vehicles, that congestion and road fatalities are not benefiting from that. And health is only benefiting if the electricity is clean. At the moment in South Africa, it's not. Secunda is the highest CO2 pollution output point in the world, and that's where we get our electricity from. So unless we go solar, hydroelectricity, etc., we're not going to have a benefit. And I think in the Cape Town situation, where we have had a collapse of the rail system and where non-motorist transport is not as big as it could be because of security issues, etc., no infrastructure for bicycles, I do think that we shouldn't forget about rehabilitating the rail system and making sure that there is investment in non-motorist transport infrastructure. That doesn't mean that what Tinus is doing is wrong, but we need to make sure that that electricity is at least clean.
Thank you. For Haneen, it's not in the chat, but just a general question, because you're so exposed to this research and you have been doing it. In this time of COVID, which you didn't touch in your presentation, is there this relation, a strong relation between air quality and COVID being more prevalent?
So I haven't really looked into this too much, but I did see a study recently come out of Harvard where they looked at COVID kind of outcomes, related outcomes, and they showed that in areas of poorer air quality, the severity of the outcome was more. So it seems like there is a link, and I think it's intuitive. It is a respiratory disease after all, and air pollution, that's one of the key routes by which it affects human health. So it looks like there is a correlation, but I haven't personally looked into that.
Yeah, and there's a question for you on expanding a little bit on methodological methods that you have been using to be able to do the linkages between the burden of disease and the air quality. Can you expand a little bit on that, please?
Yeah, so we use very kind of standard burden of disease assessment frameworks where you estimate the exposure to air pollution, ideally with source attribution, so using that full chain framework. So we model the traffic activity, we model the emissions, we model the dispersion of the emissions, then we assign exposures using a GIS framework. And after we assign the exposure, we look at epidemiological data that links the exposure to specific health outcomes. And using these associations, we calculate how many cases we can expect to be related to air pollution because of those levels of exposures. So it's a lot of estimations. I do have to put that out there. It's a lot of estimations, but we do all that we can to do validation specifically at all the different elements of the full chain. So you can validate your traffic activity, you can validate your emissions, you can definitely validate your air pollution concentrations and compare the modeled estimates to readings from monitors when you have them. And then finally, the health impacts. The final step you cannot really validate because there is no way to go out in the real world and say, oh, this specific person did get this disease because of the specific exposure. But we use, and everybody who does these exercises, these health impact or burden of disease assessment exercises, our kind of general statement, we use the best available evidence out there, and we do as much validation as possible.
Well, I would like to thank all the presenters for really bringing great information on the health impacts and transport in several parts of the world, in Brazil, in South Africa, and around the world from your work, Haneen. And I would like probably Karen or Danielle to close. There's a link that you can fill, and these presentations will be available online as well. So Karen, if you can mind to close, please.
Yes, so I would like to really thank all three speakers and also yourself, Dario, for fantastic presentations, and really, I think, very wide-reaching. And what I liked the most about this was that we were really bringing together all of these different issues to do with health in one space. And I think this is the important thing, you know, the accessibility, the accidents, the air quality, the whole thing about SDG being about health and well-being, not about illness, and the social model of health. So I think this is a really, really important, and actually we are seeing from the chat, very under-researched area. I know Marianne and Haneen very much especially put together presentations for this because it's not necessarily the normal area that you would be working in. So I really thank you for that effort. I think it was great, and it was great to have that global perspective, Haneen, as well, you know, for the thing, and also your methodologies. You make it sound very straightforward and simple, and but I know it takes a lot of work, and actually nobody's really doing it. And so I think we really need to bring this type of analysis forward, and in equity analysis within transport infrastructures and transport policy within developing cities. So thank you all very much. Dario, I know you have a million things you could have presented as well there, but you did a great job as moderator. And also obviously thanks to Danielle, Rafa and Emma for getting everything together. I think we had really good attendance. Anyone who wants to follow up, these are going to be available recording. We do Twitter. We basically, we're happy to take emails, all of us. We're a network of people, not an organization as such. So we are all of you, all of our members. So please do keep in touch with @Interlink. And yeah, we'll see you again in 2 weeks' time, I hope. And thanks very much to everyone. Thank you. Thanks a lot. Bye. Panelists, and we'll meet you in a follow-up.